Okay, let's get started. Good afternoon, everyone. Welcome to our second webinar series on artificial intelligence and machine learning in healthcare. Oh, we are delighted to have our participants. I think more than 50 participants join here with us on Zoom. And please, we have two speakers who will join us for today's webinar. And each of these two speakers will have 30 minutes for their presentations. And after both talk, we will move into Q&A session. And first, I would like to greet the first speaker, Professor Edward Yang. Hello, good afternoon, Professor Yang.
Hello, could you hear me? Could you hear me?
Yes.
Yeah, hello, good afternoon, everyone. Yeah.
Sure.
Sorry, could you hear me?
Yes.
Yes, okay,
Yes, we can hear you. Perfect.
Okay.
Yeah, thank you. Thank you for joining today, Professor Yang. So our first speaker is Professor Xuan Chia Yang, or we usually call him Professor Edward Yang, from the Graduate Institute of Biomedical Informatics, Taipei Medical University. So Professor Yang is a faculty member at the Graduate Institute of Biomedical Informatics, and mostly working with AI application in healthcare, especially with electronic health record, clinical decision support, and also biomedical data science. And on a personal note, he is also my PhD co-supervisor. So it is a great honor for me to introduce him here today. And his presentations is titled Using AI Machine Learning to Detect Medication Error from Electronic Health Record. So without further ado, we want to invite Professor Yang to give his talk. Yeah, you may share your screen, Professor Edward.
Okay, sure, no problem. Thanks for Anissa introduction. So I will show my slide.
Yes, while waiting for Professor Ed. Yeah. Oh, yeah. Yes.
Okay. Thank you for inviting me to have a lecture here, and I am honored to share my experience in how to use AI and machine learning to detect medical errors from electronic health record. In the beginning, because Anissa already introduced myself, so I just shortly. Actually, I also have 10 years experience in clinical pharmacy, but when I work as a pharmacist in a hospital, I create a lot of model, or create a lot of technology to the physician, but sometimes their acceptance rate is low. It means I try harder and create a model, but they didn't accept my product and my model. So then I go to learn the biomedical informatics. Then I know what's the reason. So today I want to share my experience to you. In the beginning, I provide one figure. It's a similar drug name, so you can see. So, okay, based on this figure, what do you think? Actually, you can see there are similar drug name. You say this gabapentin and this gemfibrozide. Okay, we don't care now. We don't care about the pharmacology, but the drug name is very similar. On the other right hand side figure is the same. Actually, they are different drug, but I can see the drug name is very similar. So it will induce, we say, the medication error, because a similar drug name, if I want to order drug A, but maybe sometimes I order wrong drug, so will induce medication errors. So like you will induce medication error, then today for the medication error, the outline will include 3 parts. First, I will introduce what is medication error, and second, I will introduce our model. We use association rule mining. Finally, I will introduce how to implement the AI into hospital. In the beginning, maybe we can think about what is the top 5 cause of death in America. Top 5 cause of death. I think most of the time we will say cancer, there's no problem. Or maybe, for example, like cardiovascular disease, hypertension, or maybe for asthma, something like that, and maybe for type 2 diabetes. But if we see a result, there are top 5 cause of death in America. You can see no problem for type 1 is a heart disease like heart failure, hypertension. Second is cancer. But you can see the third is medical error. They induce about 251,000 patient deaths. But if you go back to 2000, about the medical error is a fifth death rate. If this fifth death only induce about 98,000 patient deaths. So what's wrong? After several years, and we work harder and we create a new drug, but medical error induced the patient death increase. So what have we done wrong? Actually, most of what important is the aging population. You know, for the aging population, it means for the age is more than 65 years old. On 2025, according to WHO reporting, they say there will be 60% of all will be the aging population. So it will induce, first we say the polymorbidity. It means the more disease in one patient. Like maybe one patient, they will have a hypertension or diabetes or maybe a hyperlipidemia. And if they have a several disease, it means the patient need to take several drugs. Actually, it's not several, because sometimes one hypertension maybe in the receiver maybe 2 or 3 drugs. So it will be polypharmacy. So polypharmacy will induce the more drug for one patient. Then it will induce a more patient visits. But actually now it's a shorten physician time per patient. Actually, we not only have a polymorbidity, polypharmacy, we also have a new drug and a new examination and a new procedure. A lot of, and it's very popular now. We have a genomic diagnosis, and we also need to know the environmental factor like for air pollution and the behavior factor like do you exercise, smoking, something. So we need to have a lot of available to check, but we don't have enough time, and we also have an age population. So now we talk about the polypharmacy. So I just want to give you one number in Taiwan for the outpatient visits in Taiwan. For the average number of outpatient visits per person per year is 14 to 50 times. So you will induce about 360 million prescriptions per year. So do you think it's a 14 or 50 times is high? If you compare to American, you can see America usually only a 2 outpatient visits per patient per year, but in Taiwan it's about between maybe 3 to 15. So it will induce in Taiwan we have a 1.5 million medication per year. So if you say if you order more the drug, so we don't worry about medication safety. We just hire pharmacist and we just hire physician. And if we have enough time, we can ask the physician order the prescription safety. So we can order the one drug and check. But now I want to give one number. What is the average consultant time per person in outpatient clinic in Taiwan? In short, in Taiwan only have 5 minutes. So what is the 5 minutes? It means when we go to the clinic, and I say, I have some symptom. I have a headache and the noise vomiting, and the physician will type your symptom into computer. We say into electronic health record, like your symptom. We say subjective or objective, and the physician need to give you the diagnosis, and also need to order the medication, and then maybe sometimes we need to order the laboratory exam. So only 5 minutes. We don't have enough time. But now there are too many drugs, so you will induce medical errors. For example, assume now you are a physician and you want to order the medication. Then you want to order the medication, maybe the drug name will be the Solacin, SOLSIN. And when you type SOL, you will show, there are a lot of drugs, in Taiwan. If you want to just want to order the Solacin, SOLSIN, you want to order the tablet. You can say it will be a little crazy. They will show maybe the 20 or 30 drugs. So you will induce a medication error because of the similar drug name. Here, I want to explain what is a medication error. So it means if a physician want to order the drug A, but maybe something wrong, order drug B, so we will be a medication error. So it will result in advanced drug events. So maybe for the events, maybe should be milder discomfort, or maybe should be severe harm, or maybe induce death. So it's very serious. But it's very important for the medication error. It's preventable with proper measure. It means if you have some measure, you can prevent medication error. So according to the WHO report, actually they estimate for the medication error cost. Usually we need to pay about 42 billion to cover medication error. So you pay extra 42 million. So WHO, they hope in the 5 years, we can decrease 50% the severe or preventable, we say the preventable medication error or medication related harm. So we will say medication error kills a lot and costs a lot. Like you say in Taiwan, we have about 360 million prescription per year. And for inappropriate prescription, the prescription maybe something wrong. It's about 5%. Let me use this one. It's 5%. So error cost will be 280 million. For maybe you will induce maybe injury or death is about maybe 60,000 patients. In America, they have 4.5 billion prescriptions. So you can see they also the error cost to 25.6 billion. So it's very worse. Now I have the other question for you. So do you think what is the most common time for the medication errors to occur? Or let me help you to explain this figure. So first, you can consider you go to see the doctor, and the doctor will use a computer. We say usually we will say this a CPOE, computer physician order entry, and order the drug. So we say this is a prescribing. Then this order will transfer to pharmacy, and we have a pharmacist to dispense the drug. You can see you can take the medication into the bag. We say this dispensing. Then we will take this medication for the inpatient. Pharmacist will take the drug to the nurse. So we will see the administration. So nurse will take the drug to the patient. Or for the outpatient, patient will take the drug by themselves. But sometimes maybe patient take a wrong drug or something, so we will have complaints. So I will ask the question is, do you think about what is the most common time for medication errors to occur? Okay, let me see the result. Actually, most of the time, more than half of medication errors occur during the prescription phase. It means when physician order the medication, maybe he ordered the wrong drug, or maybe he ordered the high dose drug. For example, sometimes the physician want to order the one drug maybe for the 0.5 tablet, but sometimes maybe it's a type of error, something order the 5 tablet. So we will induce, we say the advanced drug event, maybe induce patient death. Medication errors is an old problem. So actually we just find a lot of way to prevent, we say, the medication errors. So like for the ISMP FDA, they have one methodology we call the LASA, look alike and sound alike. It means for the LASA means if the drug name is very similar, we can use the one way, say the terminator. Okay. And terminator will be like this one. Okay. You assume left this drug we call acetylcholine. Okay. The right hand side will be acetaminophen. We only focus if the drug name is very similar. So we will use a terminator like this one terminator to distinguish two drugs. Okay. I mean, based on this way, if you want to use a terminator for a lot of drug, it will be rule-based. But actually, we can implement this rule-based into, we say, the CPOE. Then it could be the clinical decision support system. But let me explain what is a clinical decision support system. You can consider this is a health information technology and provide the physician or pharmacist or nurse some suggestion or reminder when sometimes there's something wrong. Okay, and on the 1960 to 1980, we call CTS. It will be the expert system. And 20 years ago, we will call this a clinical decision support system. But now, the AI is very popular, so we will call this AI in healthcare. So actually, you say the expert system or clinical decision support system or AI in healthcare is similar. But if we use a rule-based to remind the physician, could we prevent the medication errors? But you can see this for this case is for the drug allergy reminder. It means the doctor order one drug, but the patient are allergic to this drug, so the system will show a reminder, say, oh, the patient maybe have allergy to this drug, or this drug is ACEI inhibitor, this is anti-hypertension drug. So it will induce hypersensitivity. So the physician maybe will cancel this drug. But sometimes he will continue. It may say, oh, even you show this reminder, but I think patient doesn't have this allergy, or maybe patient has taken this drug previously and without allergic reaction. So it means sometimes even you show a reminder to the physician, but physician will reject or overread it. And this is the other example for the drug-drug interaction. It means sometimes if you order the drug A and the drug B together, sometimes you will induce drug toxicity. So sometimes we say if the drug A and the drug B at the same time to give the patient, so sometimes have the drug-drug interaction. But if it's serious, so we will show a reminder to the physician. But at the same, sometimes the physician maybe will cancel the drug, but sometimes he will continue the prescription. It means he will ignore your reminder. So we were talking about what is unmet need. Actually, in AI healthcare, most important of all, we will ask, so what is your question? What is your unmet needs in clinical pharmacist, in clinical physician? So actually, our question is overridden rate of reject rate. Okay, you can soon, now we was show a reminder to the physician or something like that, a lot of reminder. But finally, what is accept rate for the physician? Okay, so the answer is for the overridden alerts, we have a study like you can go to see the appropriate of overridden alert in computer physician order entry. This is a systematic review. And based on this one, we can see from the EM-based with PubMed, Google Scholar, and the Scopus. And our keyword is a drug-drug interaction and the drug-alert interaction, and maybe renal dose adjustment, something like that. Then we selected 23 papers. So our conclusion, it means when we provide is suggestion and reminder to the physician overridden or reject rate is more than 50%. It means actually sometimes it only accept rate is only a 5% or 10%. It means based on rule base, you use a rule base, use your guideline to create the model to provide a disease, to provide a suggestion to physician. Finally, accept rate is less than 5%. So it is not useful. So what is the reason? Because it's too complicated for many rules. Or for example, if the patient have a diabetes, like this one diagnosis, and the physician will order the medication first, glucose and euclidine, you can see the drug name is very similar. And the first drug is used to treat anti-diabetes, and the second is used to treat the vascular disease. So you can see the second drug is not good for the diabetes because we will not use this drug to treat the diabetes. But if you want to create the rules, you need to create more than 100 million rules. But even you can create more than 100 rules, it is impossible for you to implement these rules into hospital because you will take much time, and when physician order the drug, you will delay something. So too many combination and exception. So AI is good solution to this problem. So we have one project we call AI to enhance prescription safety. We say ESOP, AESOP. So now I want to talk about how to create a model. So in the beginning, we want to create a model. We want to compute the association between the disease and the medication. So we need to have data. So we use a 10 million EHR, 10 million electronic health record. For the 10 million electronic health record, we have age, gender, and the patient's disease and the patient medication. It will also include about this physician behavior. So we can consider 10 million EHR. It could be real-world data. And how to compute the association, I just quick review about. We use association rule mining. If you know the machine learning, based on the machine learning, our outcome, our problem could be continuous and the category. Okay. And we have one way we call supervised learning. The supervised learning means you need to label the patient have a disease or not. Or for example, if you want to predict a liver cancer, so if you have a sample size and you label the patient have a liver cancer or patient didn't have a liver cancer. But you can see now if we use a supervised learning and we have a 10 million prescription, how could you label this prescription is appropriate or inappropriate? You have a 10 million prescription, so it is impossible. So based on this way, we can use unsupervised learning, and this problem is category. So we say this association mining. Okay, so this layer association equation. So actually, it's a relation between the disease and the medication. Let me give you the other example, much easy. Okay, so now here's hypertension, and here's one drug we call anti-hypertension drug. This is a 2x2 table, and this plus means this one plus means the patient have a hypertension and the patient take this drug. Okay, and this one it means the patient have a hypertension, but the patient didn't use anti-hypertension. So based on this one, we can compute. We say the association between the disease and the medication. Like this one, association is 2.8. So it means if the association is more than 1, we will say this is a positive association. It means this medication is related to this disease. But if the Q is less than 1, we will say, oh, this medication is not related to the disease. So maybe this is inappropriate prescription. If we can compute the association between the disease and the medication, how could we identify the appropriate and the inappropriate of a prescription? In short, maybe for here, we have maybe one prescription have the 3 diagnoses, like a diagnosis 1, 2, 3, and the 5 medication, and 1 and 2 and 2 and 5 something. So in short, if this medication could be explained by disease or could be explained by the other medication. So it means if this drug have a positive association with the disease or the other medication, we will identify this is appropriate prescription. But on the right-hand side, you can see for the M3, you can see this drug didn't have a positive association with the disease and the other medication. So we will identify this is inappropriate prescription. So if you have an equation, so you need to validate the model. So validate the model means you need to invite the expert to validate your model. So we invite the expert offline, evaluate our model or something. So finally, just in short, finally, our model performance is a 96.7 accurate for appropriate and for 45.5 accurate for inappropriate prescription. It means if our model said this prescription is inappropriate, and the physician will agree the rate is 45%. You will say 45% is high, but based on rule base, it's only 5%. Now 45% is higher than 5%. It's higher, yeah. Then this is the other publication. If you create a model, then you need to have external validation. It means you need to use the other hospital data to validate your model. We say this is external validation. So we use 24,000 prescriptions from the 6 departments across 5 hospitals. It means you create a model and the second you need to have external validation like this one. For the performance of external validation, you can see the same. We have a high accuracy, more than 80%. And for we say the negative predictive value is from the 45 to 75. It means for the cardiology, our negative predictive value is only a 45%. It means it's not good, but the reason because sometimes the medication in cardiology is complex, so the agreed rate is only a 45%. But if for the ophthalmology, you can see the accept rate, it will be the 75%. Okay, so we publish our paper we focus on the scientific analysis, US EHR data. Then we create a model and we have external validation. Now you can implement your model to hospital. Like when physician order when physician have 2 disease and 5 medication, if this drug could not be explained by the disease, they will show a reminder to physician or like this one. And I want the demo to you maybe. Okay, I think. So in here, let me explain. It means the physician order the one antihypertension drug, but you can see their disease is acute and urticaria. So they will show a reminder to the physician. This model is based on AI. Sorry, there's something wrong. Hello, could you hear me?
Yes, I can hear you, but now the slide is, maybe you can try to share your slide again. Yeah.
Okay.
Yes, please go ahead.
So can I have the question? So how many times do I have? Maybe 10 or 7. Okay, I see 7 minutes. Okay, thank you. Okay, so this started into we implement our model into the medical center, and the duration is 2 years. So we can see finally we want to check the acceptance rate. Okay.
Hello, Professor Edward. It seems that our speaker has some technical issues. While waiting for Professor Edward, I would like to invite the participants during the talk. You can also try to type your questions in the chat box, and I will try to read it after the second speaker during the Q&A session. Okay, I just noticed that now we have more than 100 participants join, so would like to share some summary while for Professor Edward to join in. So he has shown us some of the example of how medication error remain a source of mortality, and also the cost also affecting the increasing healthcare costs, but also he show us how his work related to AI using Taipei Medical University HR data. They build AI model so it can help with this checking the medication drug and drugs association across, I think, more than 10 million records of EHR. And I think the last slide before he showed the video, he showed us that the prescription accuracy for appropriate prescription is around, I think, more than 90%, and 40%, around 40% for inappropriate prescription. And here are several metrics. Maybe some of you are not familiar with this kind of evaluation metrics, but don't worry. And he also mentioned about some of machine learning model, like supervised learning, unsupervised learning. You will for participants who join our MOOC, you will learn about this concept related to AI and machine learning model in the evaluation next week when our MOOC started. Okay, so do we hear from Professor Edward? Oh, okay. While waiting for him, maybe I would like to invite the second speaker who already joined us. Oh, already joined? Yeah, Professor Edward, can you hear us? Yeah, maybe I will invite him again in the Q&A session to provide some summary of his before the Q&A. But now I would like to invite the second speaker again, my colleague, Dr. Aldilas Ahmad Nur Setio. Dr. Aldi, he's a medical doctor, and now he's working as a technical officer at the Asian. Let me check. Wait a minute. Let me check my slide. Yeah. He's now working in the Asian Biological Threat Surveillance Center and also Center for Tropical Medicine, Universitas Mada. And Dr. Aldi work at the intersection of digital health and epidemic preparedness with a focus on integrating AI into health surveillance system. And today he will present his topic related to integrating AI technologies in public health surveillance using some use case example from the Asian Biological Threat Surveillance Center. So I would like to invite Dr. Aldi. Please, time is yours. Over to you.
Yeah. Yeah. Thank you, Mbak Anissa. And hello, everyone, ladies and gentlemen. Thank you for coming to the session on the this introduction of the MOOC in UGM. And allow me to share my slide. Yeah. So I'll try to share my experience and my knowledge on this topic on the application of the artificial intelligence in public health surveillance. Yeah, so a little bit about me. Just have been said by Mbak Anissa that I'm a medical doctor. I'm also trained in biomedical informatics in Taipei Medical University. And also I used to be a researcher in Center for Health Policy and Management, Universitas Gadjah Mada, and also currently have a project with the Center for Tropical Medicine. But currently I reside in Jakarta for the technical officer as a biological threat surveillance center since 2023 until now. So yeah, while I try to introduce all of my knowledge and try to introduction at the AI, but still in the as a simplest way, so you can understand and maybe become inspiration for your future research on your study. So this is my outline. We'll have an introduction and current challenges in public health surveillance, and also I'll describe current trend in the public health surveillance system, and also some examples and experience in implementation of AI in public health surveillance, and also to the conclusion. Yeah, so as you might know that last couple of years since 2020 we have pandemic of 2019, and as we learn from since the 2020 to 2021 that we know that it's related with the transportation or global transportation, ultimately the air flight that the spread of the center of the outbreak from Wuhan, China to the other countries is facilitated by the international travel. And also, there is some studies modeling to predict how the spread is currently being predicted by the mathematical modeling or machine learning. Yeah, and also recently, related after post-pandemic, we learned that dengue, which is already endemic in Indonesia and also in the several ASEAN member states or ASEAN countries. We learned that by each year, the case is becoming gradually increased, and it could be related with the climate change. That we know that 2024 is also the warmest year since 1850. So gradually, with the warming of the earth and also global warming, we know that it also affects the arbovirus diseases like dengue or malaria. And also we can see that WHO respond by developing the global dengue surveillance platform to monitor the current situation of the dengue, and might also be seeing the forecast the future of the dengue related with the global warming. And also beside of the dengue, we also learned that pandemic not only can be caused by the natural problem such as the COVID-19, but also it can be deliberately done, such as the 21 case of the anthrax in US, that it can be done deliberately by some person or groups or countries. Terrorists can be done. For example, we learned that it's every 10 years we know that there's new pathogens that that can be found. Recently, we know that COVID-19 is the evolution of the SARS-CoV, the SARS virus, and we don't know that what's can be happen within the next 100 years. So right now, the challenges is like each of the pre-pandemic, current pandemic, and also post-pandemic. We know that we need real-time information. For example, when there is increased number of the cases, we want to know what is this true outbreak, or is it just if there is human-to-human transmission, or it's not only the animal-to-human transmission. And also how to contain what's the pathogen. Do we need to lock down? There is so many information that we collect during the pandemic session or the epidemiological session within the infectious diseases. And also with the current situation of the available healthcare data, we only can be detect the event when the person is coming to the healthcare facility and where they are seeking for the healthcare, and the doctor diagnose the patient, and we know that there is a case that included into the surveillance data. But that's already can be said, but it's already late when we want to prevent the further infection, further spread, or further pandemic. So what we need is how to we move the detection to the more in upfront ahead of the healthcare seeking, when there is infection or transmission or symptoms that might be happen in the population, so that we can plan early and provide a proper response to the event. Right now, with the what I've said in the introduction, that there is possibility of biological threats, and also involvement of the animal, and the recent globalization, climate change. We need a different approach to the public health surveillance. Right now, with the traditional method, we only know that we collect the case data from the human, from the usually from the healthcare facility. We collect the syndromic surveillance. We collect the case data, but the analysis is already too late when we want to predict if there is the future or a risk of pandemic in the future. So we need another data such as from the animal and also from the environment. From the animal, usually we collect data from the vector, usually from mosquitoes and also from the livestock, including the antibiotics and other antimicrobials. And then beside those human and animal health, we need another data from the environment that we want to know about the weather, climate change, water pollution, if there is any pollution in the air, and also risk of deforestation that it can become a cycle of the public health surveillance in the future. Right now, the WHO coined another method called multi-source collaborative surveillance that they collect the data from the health sector, animal sectors, and environment sectors, create an integrated disease surveillance from various facilities and data sources. And also we can include another sectors such as education, industry, and transport, so that we can calculate the capacity of the countries and also the risk of the exportation of the disease. Right now, this is the framework of the multi-source collaborative surveillance that it include the pre-event phase, alert phase, event phase, and also transition phase. And you see that even in every phase, we need different kind of data. For example, case report or network disease is collected during the pre-event phase, and then we need another like sentinel surveillance during the pre-event phase. And another example is alert phase. We need event-based surveillance, and then another sources needed in different phases. Because of these various multimodal data sources, current statistical method can be cope up with the analysis and can give decision making at the right time. So we need artificial intelligence that can fit with the various data sources from the case report, event-based surveillance, and hospitalization, that it can calculate the risk and also inform the decision maker to perform proper response. Okay, so right now for AI in public health surveillance, usually this is the basic of the infectious disease modeling. So usually we just use the compartment model. It doesn't need too much data, but we need assumption of the what is the pathogens, what is the risk of spread, so we can calculate the future. Like now we know the susceptible, the exposed, infectious, and remove. For example, for this modeling in Wuhan, that we can know the forecasting the situation of the COVID with a little bit of data. However, sometimes the modeling can be evolve during the epidemiological phase. So we need more data. Once we collect more data, we can do statistical modeling. It's based on the data. For example, the COVID-19 forecast happened during the early of the COVID-19 by the several universities in the US and also with the CDC, that they can forecast whether the case will be going up or there will be stable or there will be downward of the case, like that. And it also can be done with the influenza-like illness or influenza that has been done by the CDC, European CDC. You can search for the Respicash that they already have a consortium with the universities in the Europe, and they made the modeling, ensemble modeling, to predict the situation of the influenza. I think it's important to do the modeling in the influenza or other respiratory illness, since the COVID-19 is originally the respiratory illness, so they can easily become a risk of the pandemic in the future. And also with the multi-source of the data, with the public health intelligence, is another framework that combine the indicator-based surveillance and also event-based surveillance, that they combine the official sources or the historical data that issued by the Ministry of Health or the officials from the countries, and they combine with the event-based surveillance from the news, social media, and other rumors, including that they can analyze, and with the human feedback and validation, they can provide information to the officials, to the countries, might have that there will be a risk of the exportation or spread of the diseases. And also this is that we've done in the ABVC or ASEAN Biological Threat Surveillance, that we every day monitor the information and calculate the risk if there is any disease that can be imported to the ASEAN region that can pose risk of pandemic in the region. And also, usually the information of the public health intelligence can be provided in that dashboard, but sometimes the Blue Dot, that the data source that we use, is also providing the large language model that can become interface for us to gather the information from the database of the Blue Dot. So it's another artificial intelligence that can be put on top of the public health intelligence system. And also we provide, this is the current project in Center for Tropical Medicine, that we work with the Canada, with the IDRC, and also with the York University. And currently we just got another funding from the FCDO of the United Kingdom, that we can implement the artificial intelligence in the national public health surveillance. This is the framework that we offer, that we can provide integrated surveillance system, predictive analytic. For now, with the use case for the dengue, we included into the EWARS system or SKDR in Indonesia, and also we provide LLM-based syndromic surveillance to automate the reporting of the syndromic surveillance from the healthcare facility or puskes. This is the prototype of our platform. We use the spatiotemporal graph neural network that combine spatial, temporal, and also environment variables from the weather, from the climate factors, environment factors, and also geospatial factors to calculate the risk of the outbreak of the dengue. The dataset we use the EWARS and also geospatial and also temporal with year date, and also weather data from OpenWeather, and also NASA Power. We include the cloud, the humidity, precipitation, temperature, and wind pressure, speed and direction, and also vegetation index from the NEOMOD. And then we built the platform so that it can be easily be used by the officials, that they don't have to do the analysis themselves, but also can use the platform to calculate or predict if there is any outbreak. And this is for the prototype of the LLM base, so we're still working on it, and we use the clinical notes, laboratory exam value, and medical description. And usually we done this in NLP, but we can use large language models with the same concept that with the NLP. So we done the classification that the LLM can predict or classify whether the patient has dengue, malaria, or other Rubella cases, then directly submitted to the SCADER or award system. Okay, so I think this is my last slide. So my key takeaways is if there is any change in climate, technological and demographic has altered our perspective on disease dynamics and spread. Integrated surveillance with the One Health approach and multi-source collaboration surveillance can help data-driven decision-making in mitigation of biological threats. And also various AI technologies ranging from predictive analysis to generative AI can help provide early awareness to prepare response plans. So I think that's my presentation. If there's any questions, I will happily to discuss. Back to you, Mbak Anissa.
Yeah, thank you, Dr. Aldi, for the presentation. So, Dr. Aldi have highlighted the challenge in early detection surveillance and where healthcare data often comes too late in the infection timeline, and also emphasized the importance of One Health approach and some example of integrating AI, especially for dengue surveillance. So we can close the detection gap and strengthen the preparedness against biological threat. And we are now moved to the Q&A session, and let me check if Professor Edward has back with us. So thank you, Professor Edward, for rejoining. We'll now have this opportunity to continue with the Q&A session. But before that, would you like to maybe summarize your provide some key takeaways? Yeah, from your previous slide.
Okay, so I just talk directly for so I'll take a home message. We know we can use a CDSS to provide a solution to identify the inappropriate prescription. But now, if you want to create a model successfully, you should combine the EHR data and the AI. You cannot only use a guideline to create a model. You need to implement the EHR, because sometimes we say guideline is not equal to physician behavior. You want to provide your model to physicians, so you should include some physician behavior data. So this is my take-home message. Thank you.
Okay, yeah, thank you, Professor Edward. Now we are open to our Q&A discussion. I think I saw the participants already posed the question. While waiting for the curated question from the participants, maybe I saw Dr. Zamzam, our PhD student at the university at Faculty of Medicine, has posed some question. Zamzam, would you like to also ask the questions directly to the speaker? If you're able, you can raise your hand. We will enable the speaker for you.
But before this one, I already see one student have a question on the message,
yes.
So maybe I can answer this question directly.
Oh yeah.
So
sorry, Professor Edward. He would like to ask the questions directly.
Okay.
Yes, he would like to. Dr. Zamzam, yeah, you may open your video and ask the question directly. Yeah.
Good afternoon, Mr. Yang.
Yes, please. Yeah.
Thank you. Thank you for the presentation. I'm Zamzam, a student at UGM and lecturer at the Faculty of Dentistry UGM, and also the owner of EMR company called Carigi Indonesia right now. And the product I'm developing currently focus on applied AI in EMR, which it includes analyze interaction like your presentation before, within the larger framework of AI as a clinical assistant support systems. And this product is being tested in my dissertation, and I'm using both paid API models like Gemini, Cloud, DeepSeek, and GPT, and open source models such as Mistral, Llama, and Lava, which are installed in my internal server company. And my finding is that the best performing models are from the paid APIs. The top performers are Cloud, and obviously due to their significantly larger training data. And my question is, given that using a paid API model is the best practice, how can I ensure that this black box kind of model is safe, ethical, substantively correct for use as a CDSS, clinical assistant support, considering we cannot fully break down its internal process, Mr. Yang and Dr. Adilas. Thank you.
Okay, so thank you for your question. So can I respond directly?
Yes, please go ahead.
Okay, first you say the question about the black box. But my question is, even you didn't have a black box, then you create your model and provide the suggestion to physician. If they don't accept, it is not useful. So usually we focus before we talk about the black box. Sometimes we focus on the accept rate of a physician. So we say you should validate by the expert. For example, for my model, usually you can say the accept rate is only a 50%. It's not high, but compare rule-based 5% is enough something. So for the CDSS, we say it just provide a suggestion to physician, not make a decision, just provide the suggestion to decision and help them make a decision. So actually, if your accuracy is more than 50% is enough, I say for the drug generation something. And the second is say for your model, for use of different large language model, like now you say the paid API like a ChatGPT maybe have a better performance. And the other issue is in the future, if you want to implement your model into hospital, could hospital use ChatGPT? For example, if you want to use my patient data, so did the hospital allow the patient data upload to ChatGPT and use your model? So it's the other questions. So if the hospital could not accept use cloud ChatGPT, so sometimes we will use a local model. Like now, I like Gemma 3 something. This is my suggestion. Yeah, I'm not sure did it satisfy with your?
Yes, Mr. Yang.
Yeah, thank you.
Yes, we agree because we our students also tried this comparative evaluation between the commercial LLM with the localized LLM, and it's also one thing that maybe the participants need to aware is related to data security. So as Professor Edward mentions, maybe to use the local LLM like Gemma or the others. What is it like Llama? And then you can use other method like retrieval augmented generation to help reducing the to mitigate the bias and also hallucination. And now maybe I would like to invite Dr. Aldi, if you like to elaborate more, maybe from the perspective of the surveillance. Yeah.
Yeah, for my case, yeah, I'm also implement using the LLM for our research. So, yeah, what's Dr. Edward said is right. So, how our model will be accepted by the doctors, physician, or even the hospital management. So, we discussed with the hospital management that they also always concerned about the the confidentiality of the data. So we propose that we build our local LLM. So we plan to use the DeepSeek model and fine tune. So we only need the smaller, maybe 7 billion parameters, and then fine tune the model, because the purpose is just for classification. No, it's more like simpler purpose. So they accept that if we do it with the local model, that it can be done like that. So right now LLM is become trend. It not only for the classification but also for generating maybe the response plan or the bulletins that can be issued by the officials to the population about the current situation of the infectious diseases. So I think yeah, the black box side is we can set aside about the concern, but how the model can be accepted by the management or the patient or the physician. I mean, I think that's it.
Thank you, Dr. Aldi. So he added that fine tuning is also another strategy that we can use. We are using a smaller parameter of LLM, but when you fine tuning it, probably it can improve the performance of the model. Okay, thank you for the question and also the answer. I would like to invite if there is any other participants who would like to ask to our speaker. Yeah, or maybe we can try to see from the PPT question. Do we have? Yeah, thank you. Okay, while waiting for the organizer to see the screen, yeah, we have some question from the participants that already created by the organizer. So the first question is from Hanifa. It said that many HR contain unstructured data, such as physician note. What are the main challenges in using this for medication error detection, and how can AI help overcome them? Maybe the first I would like to invite Professor Edward.
Okay, sure. Yeah, actually for EHR, they include about, we say, the cold data, structured data like a disease and the medication, and the unstructured data like a physician note. We talk about maybe discharge summary and admission something. So how we use the medication error detect? Actually, most of the time we focus on the use of disease and cold data like a disease code and the medication code and for laboratory code to prevent the medication error or something. But second, in the future, if you want to use AI, you can change, for example, maybe the patient have a lot of disease, but for the ICD-9, maybe only code one disease. So you can use AI to analyze their discharge summary or maybe their physician note to know the patient have the other disease. So you can use AI for unstructured data to get more information. So it means use AI for unstructured data and get some output. And this output could be, in the future, could be your input to the model or something. So transfer the data is my suggestion. Yeah. But you said a second, how can AI have overcome them? So by the way, it depends on the acceptance rate. Sometimes if your model, even your model is pretty good and the acceptance rate is right or something, but there's one problem. Usually the consistency between the physician is not high something. It means we invite a physician to help us to label the prescription appropriate and inappropriate. But actually we find that sometimes their consistency is not high, only a 0.7. It means even this physician consider this prescription is appropriate, but the other one may be considered is inappropriate. So I would suggest based on this one, if you want to prevent or maybe show a reminder to the physician, sometimes if they reject, you can receive the reason why they reject this reminder and improve this one. So you can focus on the specific question, something, you'll be much better. It means in the beginning, you have the data and use your data to knowledge and use the knowledge to create a model implement to the hospital. But when physician use this model, you need to receive the information from the patient or from physician, then polish your model again. You will be the data recycling. This is my suggestion. Thank you.
Okay, yeah. Thank you, Professor Edward. I just remember that in your slide earlier, you mentioned that you invite expert to validate the drug prescription. I just want to ask, like, how many experts were involved in validating this prescription, and like how long the validation process typically took? Because I think data quality will be the most important thing that will affect our model.
Yeah, it's a good question. So for the external validation, actually, we invite we have 5 departments. So each department we have 5 departments like cardiovascular disease, neurology. So each department we need to invite 3 physicians. So it means sometimes if their first one, the second one, maybe their opinion is not consistent, we have the other third opinion or something. And usually, if you want to validate the prescription, usually take 1 month something. Because the physician is very busy. Yeah, sometimes even you provide you can label and evaluate on the website. They don't like it. Yeah, sometimes we use a paper base, because sometimes they will go to outside. We prepare the paper and maybe on the train and the bus, maybe on the airplane, they can label the result. Then we take it something. You're much easy. This is my suggestion. Yeah.
Okay, thank you for the answer. So I would like to move to the maybe jump to the third questions from Dila. What strategies can be used to build trust among healthcare workers and policymakers in adopting AI-driven decision support system? Maybe for these questions, I would like to invite Dr. Aldi, because you're mostly working with the stakeholder from different countries, around Asian. So what will be the biggest barrier to integrate this, and what strategies can be used to build trust among healthcare workers and policymakers to use AI?
Yeah, so usually what healthcare workers and policymakers concern about the AI is usually with the confidentiality of the data and also data sources, or what data that we use. But it can be done previously with the co-designing with the policymakers, what solution, AI-based solution that can be developed based on their pain point with their problems in the field, and also maybe we can do the training on the for in the surveillance we use do the infectious disease modeling, so they know how AI is working and how it can provide information or the analysis result that can provide better decision making for the policymaker. So actually, the healthcare workers and policymakers are eager to adopt the AI, but they need to know what's the limitation and what can be done and what can they do with the information from the AI. So I think they have to understand all of that.
Yeah, thank you, Aldi. Before we move to the second question, maybe Professor Edward, if you like to add some input regarding this barrier to integrate this within the clinical with clinician in the hospital.
For research, for a graduation, if you only have 2 years, please don't want to implement your model into hospital. It take a long time, even you have a model, if you want to implement your model into hospital, you need to negotiate with their dean and director and you go to their report. So before you implement, you negotiate about 6 to 1 year. So if you are a medical student, you only have 2 years if it's not enough something. And the second is very dangerous. Because if you want to implement your model, you need to have an idea. First we call a silent model. If they agree to implement your model, silent model means they can implement your model. Then if you detect maybe there's inappropriate, at that time in the beginning, should not show a reminder to the physician, just collect the information. So it means in the beginning, implement the model to the hospital, and for first month and the second month could be the silent model. You will know what is your alert rate and how many alert do the physician will receive or something. Because maybe some physician they will receive maybe 100 alert, and maybe only 1 or 2 only receive 1 or 2 something. So, but you don't know because before you implement your model to the hospital, you don't have an idea. So if you want to implement in the beginning, should be the silent model. It's very important. Silent means you implement your model, but you will show a reminder to the physician. This is my comment here.
Thank you for the answer. I saw that one participants also asking Dr. Purva asking about the estimated cost to implement the AI solution in the healthcare setting, also in the population level. Is it feasible to deploy such a solution in a smaller hospital with limited infrastructure? What will be the strategy for this? Maybe Dr. Aldi, would you like to respond first?
I can answer exactly how much because it's still ongoing work, and but at least for the span of time we are given for like 4 to 5 years is already feasible to implement. So from the gaining the problem insight from the policymakers and discussing about the solution, how the solution will be developed, what kind of the solution, what's the interface, how it can be embedded into the business process of the health office. So it's a marathon like that. So for the estimated cost is I think in terms of Indonesian rupiah, 2 billion is still it's the minimum of the
The minimum how long is it?
for
Yeah.
4 to 5 years.
4 to 5 years. Okay. Yeah. Thank you. Thank you, Dr. Aldi. And Professor Edward, would you like to elaborate more, maybe using
I
time?
agree with Dr. Eddie because for
Yeah.
my research, you can see for on 2000 on my new research, we create a model on 2021. After we implement
Okay.
model on 2023, then finally we successful now result on the 2025. So it will be a 4 to 5 years. So it is
Okay.
impossible for I create a model this year and implement it in the hospital and get a result. No, it's impossible. Yeah. And most of the time, if you want to implement a model to a hospital, I have one experience. So sometimes my model is our model maybe induce the hospital health information system broken. It means we want to provide a suggestion to the physician, but maybe there's something wrong. So your model induce a broken for the hospital health information system. So at that time I work maybe until 12 hours something. It's a crazy something. So if you want to implement your model into hospital, first be careful for your response time something. And the second, I agree with Dr. Edis. He said usually we say the data is king. If you have the data, data is king. But we say the user interface, and the user experience is queen. And the data and the king, and it means you have a data and have a the user interface and the data experience. So data and so king and the queen can work together. But most of the time we only talk about the data something. But so if we only focus on the data, it's good for the master student. But if you want to implement it into the hospital, so it could be done the PhD student, but you don't know what is a user interface.
Mm-hmm. Okay.
But actually, sometimes we didn't teach about the user interface, because even we are biomedical informatics, we only take how to use a deep learning, create a model or something. And we can teach very detailed and provide a GPU something, but we don't know the user interface a lot or something, yeah. But second issue, even you know how to create the user interface, it doesn't mean the hospital allow you to create a user interface in their hospital, in their CPOE. So you can use their CPOE system to only show the one message. So you will see, even you have a good model and show the one message, but your user interface is send the other reminder. So it's not useful.
Okay. So can I say then we have to prioritize user-centered services when we build our model. So because sometimes as someone who is working in the health informatics sector, our perspective is like just what kind of new technology that we can help, and sometimes we forgot about what is really the client or those who is working, the target participants really need it. So based on your experience in your sectors, what will be how far are we like using this AI adoption, prioritize user-centered services when we implement our model?
Yeah, and by the way, you also need to have good friends. Let me explain, because we implement our model in the beginning so into one department, even maybe the one hospital, but in the beginning only one department and only one physician. And when we implement our model, the response time is about 6 seconds. In the physician order the drug and it's pending after the 6 seconds, and we show the reminder or something. So it will be, but in the beginning we don't know how to modify something. So if you have good friends and they can help you can see the clinical trial something. So then we can implement the response time from in the beginning should be a 6 seconds and the 5 seconds, 4 seconds, and we can shorten into 1 second. Yeah. But we know before in the beginning should be 6 seconds. So it's too long something.
Yeah. Thank you, Professor Edward. Dr. Aldi, would you like to elaborate more on this issue? Yeah, because you're mostly working with various stakeholders from different programs.
So the development is so what is it, the question?
Like how far are we the AI adoption is from prioritizing the user-centered service comparing to us researchers who want to implement new model.
Yeah, so if we talk about implementation, like I said, we're talking about marathon. So yeah, we can develop model for the novel, for the what is it, for the publication, but for the implementation, sometimes old models like neural network or the regression model is already enough to serve the purpose of the users. So I think user-centered is important because we know what's the pain point, and that's the point where our model or our innovation can be used by the stakeholders. If not, they only when the project done, then they won't use the solution anymore. So I think user-centered is important.
Yeah. Thank you, Dr. Aldi, for highlighting the issue related to user-centered services. And I think I missed one question from the previous participants from Risky. I think he's asking more technical about the issue related to sensitivity and specificity, if I'm not mistaken. So in real world implementations, like how do we balance this specificity and sensitivity in our performance? Maybe Professor Edward, if you like to add some answer. Yeah. What is the strategies to balance sensitivity and specificity to avoid? Oh, it's related to alert fatigue for clinician, because you mentioned in your project that you have alert overridden project. So he's asking about the strategies to balance this. Yeah.
It means you need to provide a precise reminder. You cannot only use a rule base. Then if you balance the sensitive and the specific, it means in the beginning you have a silent model. Then you can collect the information from the physician and make the threshold something. And finally, after you run the 1 year or something, you also have the data. Actually, now you can create a different model. What does it mean? When you want to show the reminder to the physician, you can predict the physician will accept this reminder yes or no. So it's very interesting. If you have a lot of the feedback from physician, so you can create one model to predict the physician accept rate something. So you can how to say, because even you can provide a good model or a good suggestion, it depends on the physician accept or not or something. So yes. Sometimes even the send reminder, send prescription, but if you send reminder to the senior physician, they will reject. But for the junior, they will accept something. But if you accept a lot of information in the future, you can predict if they will reject your reminder, you should not send a reminder to the physician something. This is based on the AI engineer or something. But actually, if you based on the medicine, even they will reject, you need to send a reminder to the physician. So this is complex. Yeah. So this, in my opinion, it means in real world implementation, you should have a real world data to to balance the sensitivity and the specificity. It means you have a feedback to balance. Yeah. You cannot only use maybe the threshold, based on the physician behavior, should be precise reminder and the precise suggestion. Yeah.
Okay. So maybe this last question from me, because due to the time limit, you mentioned, but we have to have the balanced data set. But in real world implementation, specifically in the health sector, when we are dealing with a rare disease, it's quite hard to find a balanced data set. So usually we like a very limited positive cases comparing to the negative cases. So what will be the strategy to maintain our model performance when our data set is not balanced? Yeah. Maybe the first questions, like to invite again Professor Edward to answer this, and then Dr. Aldi, you can elaborate more after Professor Edward. Yeah.
Maybe quite invite the Dr. Edis. Yeah. Maybe he have more experience in this one.
Okay. So yes, because especially when dealing with like dengue cases or cancer in Indonesia, we usually have very limited cases of like cancer or not like communicable disease. So what will be the strategy to reduce this imbalanced data set, so while maintaining our model performance?
Yeah, it's also my problem when I done
Okay.
my thesis. So
Yeah.
I used to do with the even yeah I forgot the but yeah, I try to balance the data, but turns out it's not the best solution or best method to do
Okay.
because it is not representing the real world data.
Okay.
But recently, with the rise of the with the uh, uh, synthetic data, actually we can do the synthetic data because, for example, there is another population that has more rare disease, and they have more records because they have good surveillance, they have a good diagnosis system, so they can capture more rare disease like that. Or so we can use synthetic data and apply to the other population, for example.
Yeah.
But in our case, because dengue, we do the prototype or pilot implementation in Yogyakarta, which the dengue cases is not so many, range from 0 to 80 cases.
Okay.
So we try to implement the synthetic data and simulate the outbreak. But that's we try for the validation phase. So we want to know which when we train with the real world data and we propose or we introduce with the synthetic data how the model can recognize the pattern. So that's our exercise with the synthetic data. But you need to have good experience or good expert in using the synthetic data, so you understand the performance, the model is good with the synthetic data, and then try to implement with the model.
Thank you. And
Maybe based
Professor, yeah.
on the real world data, actually we have now for the EHR, if you say it's a rare disease into the EHR from the one hospital or maybe one country something. So if you can use a ChainNet that can provide the international and the collaboration data, maybe you can solve this problem. But on the other issue, even they provide a huge database, but because you cannot download the raw data, so sometimes even the model show the performance is good, but it is not really good because you cannot download the data or something. So actually, this is also my question. If I think this is a rare disease, usually for academia, I would suggest student maybe you can select the other topic. It will be much better because you will use the other methodology to balance you try to a lot of methodology to solve the imbalanced data issue, but maybe you can select the other topic will be much more quickly. Is my suggestion here.
Yeah, thank you to all of speakers who answer the questions. And due to the time limit, we would like to end the Q&A session. And today's session highlighted how AI can improve patient safety by reducing medication error and how it can also strengthen epidemic challenge through public health surveillance. And thank you once again to our speakers, Professor Edward and also Dr. Aldi, and to all participants for your thoughtful questions, and especially for this 102 participant who is still join with us until the end of the session. With that, we conclude today's webinar. We look forward to participation in the next session of the series. Thank you.
Yeah. Yes. Thank you. Thank you, Anissa.
Thank you, Professor. Thank you, Dr. Aldi.